domains. So you can find out that, in how many areas this MS is affecting as compared to healthy control. So not only episodic memory, information processing, verbal fluency, visual spatial, language, and simple attention. So a lot of domains are affected in MS patients if you are able to pick up. It's very hard to pick up these dysfunctions clinically on clinical examination, but there are batteries to pick up those dysfunctions, and there are ways to even address those. So that's what we'll be discussing today: how to pick up this cognitive impairment and how to address that cognitive impairment in your patients. So it affects in many ways. It affects the employment, it affects the relationships, social functioning, daily activities, physical independence is affected, even leisure and activities are affected. And in terms of safety, driving, it becomes a problem in MS patients who have this cognitive problem. Falls become a problem. And it also affects their decision making, adherence to the medication, symptomatic management, even rehabilitation. So because if you have someone with cognitive impairment, they will have problems in taking medications, remembering the instructions, and following up with your plan for the treatment. And that overall basically affects quality of a life of patient and also the caregiver. So that's an important issue. Now, this issue is also a burden issue and a cost issue. Now, because in Western world, everything is measured with the cost. So if you have a MS problem, and if you have a problem in MS who have a lot of cognitive component, then that adds to the cost of MS care over a period of time. And this is important, that if you can cure the MS, you can go to the no evidence of disease activity. But still, if it's a neurodegenerative problem and the brain is going to be degenerated over a period of time, and you are unable to stop this neurodegeneration with the medications, then over some period of time, these patients will be requiring kind of care. The people who have the different kinds of dementia, they kind of require treatment. So this is something which is important, that not only we have to prevent these patients from future disease activities, but we have to prevent these patients from developing dementia or severe cognitive dysfunction. So at least these patients who in the young age develop this MS, they don't become cognitively impaired at the advanced stage of their life. And even this is not only present in advanced MS. That's what we used to think, that a cognitive impairment occurs, but it occurs in advanced MS. So it's not the case. And this is a data of more than 1,000 patients, multi-center data. And what we are learning, that if the patient has clinically isolated syndrome to us is a kind of benign disease. We think that it's a very mild form of MS. Actually, clinically isolated syndrome, 35% patient with clinically isolated syndrome, they have cognitive dysfunction. And if you have relapsing remitting, it becomes more. If you have secondary progressive, and even in primary progressive, it's 90% patients have cognitive impairment. So overall, it's about 46%. That's the data. So if you kind of start looking at cognitive impairment in your patients. Now, there are two important variables in this cognitive dysfunction. Number one is age, and number two, disability. It increases with age. So there is a disease burden and there is an age. If you increase the age of the patient, you will see more cognitive dysfunction. So for example, in an 18-year-old MS patient, the cognitive dysfunction is about 28%. In 40 to 50 years old, it's 50%. And if you have a patient who had MS or has MS at the age of 60 to 70, the cognitive dysfunction is 85%. So age is an important determinant and predictor of cognitive impairment. That's one thing. Number two is the disability. So if the EDS score is high, then cognitive impairment becomes worse. So it means if the disease burden is high and disease burden is causing more motor disability, so that's also at the same time causing more cognitive dysfunction. So it's kind of closely related to aging and patients who have higher disability. And this is something which we have to keep an eye, and we have to identify patients especially who are more than 40 years old and who have a higher disability. We have to identify that how many of them are cognitively impaired, and then we have to find out way that how we can address those problems. So there is a difference in prevalence in terms of the type of MS, in terms of age, and in terms of the disability. Now the question is, now we know that it's there, how are we going to find out? And that's the tricky part, because that is still going to be a lot of testing to find out. There are very simple tests to find out the neurocognitive dysfunction, and there are a little bit complex tests too. So there are very good recommendations that how you could find those tests out. There are batteries for tests. Will be briefly discussing. But now the thinking is that all patients with MS, they should have at least one time neurocognitive assessment by a neuropsychologist battery. You can do it in your clinic if you have time. It's not, they are not really rocket science. Even neurologists or neurophysicians, even nurses can do it, because they are very simple batteries of tests and there are simple answers to that. But you can calculate a course and you can find rate and score, and you can find out that what kind of problem is there, and you can send the patient to a neuropsychologist with the test. And that's what we are working on with the neuropsychology team. We are going to organize a workshop with the neuropsychologist to develop a battery of tests that can be done in our patients in our language, and that can be done to assess the cognitive dysfunction in the local language, and that can be done even with an iPad or a tablet. So this is something which can be done, but assessment is important. And there are these 4 major tests, I think, which are the screening tool, which are validated. I don't know if they have been validated in Urdu or not, but they are very validated in multiple languages, and probably they are very validated in other disease conditions, not maybe MS, but other conditions. But we have to find out, and we have to work with the neuropsychologist. So the most important one is symbol digit modalities test. Then you have processing speed test. Then you have computerized speed cognitive test, and this MS neuropsychological screening questionnaire. So even because we are not using it, so we are not very well aware of these batteries. But these batteries are going to give you answer that what kind of cognitive dysfunction you have and which domain the cognitive dysfunction is. Some of them are very brief tests, and brief means that you can do it in your clinic. So it takes about 5 to 7 minutes to do a battery. So BICAMS is a brief testing, and there a lot of neurologists in their clinic, they do it without the help of psychologists. And most of these tests are basically done by the nurses. So a lot of MS clinics, they have a nurse who is doing all these testing and recording these tests. So that is also that you can, if you have a nurse in your clinic, or if you have a resident or a trainee who is interested in this, they can learn this test and they can do it on all MS patients. So they are very easy to do. So there is a BRB, which is brief reputable neuropsychological battery, and that was started by Dr. Rao in 1990. There is a minimal assessment of cognitive function in MS, and there's a BDI, which is Beck Depression Inventory. Now, BDI is also important because sometimes cognitive dysfunction is related to depression. So you want to make sure that this cognitive dysfunction is not related to depression. It's basically an effect of multiple sclerosis. So it's important that you rule out depression in patients who have cognitive dysfunction, because sometimes they have this pseudo dementia kind of effect in MS patients. So these are the recommendations, and these are some of the tests by a battery, which is called the recommendations for BICAMS, which is Brief International Cognitive Assessment for Multiple Sclerosis. And they have asked 3 tests, which is symbol digit modality test, which is called SDMT, CVLT2, and BVMTR. And this takes about 15 minutes. And any nurse or any doctor can do it. You don't have to have a neuropsychologist to do this test. So this is something which we are going to do a workshop with the neuropsychologist, and then we'll be able to learn these tests by ourselves, and we'll be able to teach our neurology community, our trainees, that how to do these tests for our patients. So these are the 2 batteries. There are longer batteries. For example, there's a BRB battery by Dr. Rao that takes about 30 to 45 minutes. And this MS assessment long battery, which has 6 or 7 tests, that takes about 90 minutes. So this is a test process that can be done. Okay. So I welcome CEO of the Sehat Sahulat program, Dr. Arshad. He's here. So I'll try to finish my talk and we'll get you in as soon as possible. So underlying physiopathologic process it's very interesting that how this MS causes this problem. So MS affects many domains of the brain, and we'll be quick. That MS not only causes white matter problem, but cortical lesions, and we have microstructural alterations in the normal appearing white matter. So you see it on MRI, it looks normal, but there's a microstructural problem. Hippocampal atrophy is a feature of MS, and that's what is suggesting the neurodegenerative model. And cerebellar hemisphere atrophy is also a part of MS. So many of these substrate, they lead to this neurocognitive dysfunction. And you can now, there are ways to detect this issue with the advanced MRI technique. For example, if you see patients who have a normal cognition and look at their MRIs as compared to patients who have cognitively impaired MRIs with MS, you see more volume loss or degeneration of the brain. So volume loss of the brain is an indicator of cognitive impairment, and that's pretty well documented in literature. So this is one way to measure that if the volume loss is pretty high, then you can see. The other way is to look at thalamic atrophy. So there's a good data. The thalamic atrophy is associated with the cognitive impairment. Hippocampal atrophy is associated with cognitive dysfunction. Cortical lesions are associated with cognitive dysfunction. So you can pretty much predict cognitive decline in MS based on MRI findings. So there's a lot of literature and data related to MRI findings, that how gray matter volume loss is a predictor of cognitive decline in multiple sclerosis patients. And this is some of the data that lesion volume is also important, that leads to disability. And with the functional MRI, you can pretty much identify the areas of the brain which are less functioning with the MS as compared to normal control population. So you can see that which part of the frontal lobe and temporal lobe are being affected. And sometimes you don't see any lesion there, but the circuitry of the brain is affected because of the multiple sclerosis. So this is how it works. And basically the network efficiency of the brain, it goes down over a period of time. And that leads to basically structural damage and the cognitive dysfunction of the multiple sclerosis patients. So you can pretty much identify by different MRI technology. This is a big study which was published in JAMA Neurology, which they have even identified the correlates of MRI findings to type of cognitive dysfunction in different types of the brain. For example, now there are phenotypes that how you can identify the type of the cognitive problems. So patients who have, for example, verbal memory or semantic fluency, they will have this part of the brain affected. Patients who have severe multi-domain deficiency, they will have problems in these parts of the brain. So pretty much they very well correlate with the structure and function of the brain. And this is a slide showing that, you know, how it is affected and which parts of the system are affected. So for example, in early MS, you know, you have a large number of patients who has mild verbal and memory kind of issues. But if you go to primary progressive MS, then that problem goes high. So there are 5 domains, and each domain you can identify that which part of the domain is affected in what type of which level of the MS. Now we go quickly to the management strategies. Now, once you have been able to identify the cognitive impairment, how you are going to fix the problem. So there are 3 things. So you have to know, number 1, you have to identify patients who have other factors which are affecting cognition. For example, depression, fatigue, sleep disturbances, sleep apnea. So you have to kind of address those issues. Number 2 is medications. There are certain medications which can cause cognitive impairment, especially if they are taking anticholinergic medications, if they are polypharmacy, if they are taking cannabinoids, which sometimes a lot of people in Western part of the world, they take cannabinoids for fatigue is MS. And you can now see with the MRI signs of disease progression. Now, there has been some data on how you can treat, but this is still, it's not part of the guidelines, and there are no good randomized control trial that can you use your routine FDA approved Alzheimer's disease medication for these patients to improve the cognitive functions. So far, there is no good data. People have used donazepam, rivastigmine, galantamine, which are anticholinergic medication which we use for Alzheimer's disease, and some people have used stimulants like methylphenidate and memantine, even NMDA receptors. This delphamepridine is a medication which is used in MS that has shown some effect on cognitive function. But we have looked at the whole data. A lot of these DMTs, they also improve the cognitive function. There's not much difference among them. So it's important that once you treat these patients with DMTs, you also improve the cognitive function. Now, there are 4 major ways to treat this cognitive function. Number 1 is preventive, which is enhancing brain plasticity. So this is something which you can do in your MS patient that they don't even have cognitive dysfunction. You can improve their brain plasticity by brain exercises which are available, and most of them are available on tablet or internet. You can do restorative therapies. There are compensatory and there are palliative mechanisms. So there are, and this is a lot of data coming from different kind of programs to improve cognitive functions. So for example, this is a popular program in Western world. It's called RihaCom program, which is basically a computer program with training modules. And this data is showing that there's a huge effect on the brain function if you use these kind of brain training modules in different segments of the brain. Brain HQ is a model, attention process training is a model. So they are all computer-based program where you can go and drill and improve your learning exercise or special memory or memory function or those kind of things. So these are kind of the rehabilitation approaches for these. These are compensatory approaches where this is also a different kind of non-computer based learning program, but with a special kind of therapy to the brain, especially learning and memory exercises or visual imagery training. You can improve the brain function by these exercises. And if you look at the results of these studies, they are showing that they have a very good medium to large impact on the brain function. So the other mechanisms are this modified story, memory technique, visual imagery, general compensatory strategies. And what we are thinking that we should develop some kind of guidelines to our neurology community and Pakistani doctor community, that if you have patients with cognitive impairment, just brief guidelines that how you should diagnose, what kind of test you do, and what kind of rehabilitation therapy you should be able. So, and a lot of time you can just combine all that therapy. So pharmacological intervention is important, aerobic exercise is important, virtual reality, augmented reality is important, and sometimes even non-invasive brain stimulation could also be an important with, there is a lot of recent literature and training for that related to cognitive impairment in brain. So in conclusion, cognitive impairment is a part of many people's experience of MS, and it's even independent of disease subtype. You can see even patients with clinically isolated syndrome, and it has a negative impact on many aspects of life. So it's also independent of physical disabilities and have a negative prognostic role. So brief assessment is important and regular monitoring of cognition is important. So it's very advisable that we should do this thing in addition to the therapeutic decisions we are making. And we should be able to understand the physiopathology of this cognitive impairment and how can this we can treat with the novel therapeutic targets. So cognitive rehab strategies are important and that have given and shown a lot of positive results. So these are something which we can execute in our patient population for future. So hopefully we have more information and we are more sensitized to identify these patients and treat these patients to improve quality of life of our MS patient. Thank you very much.
Thank you, Professor.
Maybe we can first invite Arshad Saba and then we can take questions at the end.
Yes. We can start the next session immediately and we can take questions in between.
Yeah. We have a lot of questions on post. We'll not be able to answer.
Okay, so due to shortage of time, we will skip the break for now and we will move to the final and fifth session of our conference today. For that, I would like to invite the chair of that session, Dr. Farheen Niazi, please. She has more than 13 years of experience in neurology and she is currently serving as a consultant neurologist in the city of Islamabad. She's a member of Royal Colleges of Physicians, the UK, and she's also a member. She also has specialty certification in neurology from Royal Colleges of UK and Association of British Neurology. She's also a fellow of European Board of Neurology. I would also like to invite Dr. Shabir and Dr. Waleed Shahzad as a co-chair for this session.
Thank you, Dr. Naveed. So we understand that all of you are tired, but we'll be dealing with an interesting topic in this session. So which is our biggest challenge in MS patients, the cost. So this session is all about patient's perspective and resources. So our first talk is by Mr. Arshad, who is the CEO of Sehat Sahulat program. And he has more than 25 years of experience in health insurance, financing, and universal health coverage. So let's see how he can guide us about this issue.
Thank you very much, Ji, for the organizers to inviting me here. आपने मेरा ख्याल है कि इस कॉन्फ्रेंस के आगाज से लेकर अभी तक काफ़ी सारी टेक्निकल चीज़ें, क्लिनिकल चीज़ें और जो इस तरह अभी ब्रेन को डाइसेक्ट करके डॉक्टर साहब दिखा रहे थे, तो वो सब चीज़ें तो आपने सुन ली होंगी. तो आई एम गोइंग टू गोना टॉक समथिंग डिफरेंट, समथिंग न्यू. हाउ द पुअर पेशेंट ऑफ पाकिस्तान is today resourceful. वो क्या हुआ है पिछले 7 सालों में जिसने पाकिस्तान के बेचारे पेशेंट को जो जिना अस्पताल, मेयो अस्पताल, पेम्स अस्पताल के फुटपाथों पे MS समेत बहुत सारी बीमारियों का शिकार होके सिर्फ परचेजिंग पावर, पेइंग कैपेसिटी ना होने की वजह से जिंदगी की बाजी हार देता था. What is the difference? So I will try to be very brief. आपने सेहत कार्ड का नाम आप सब लोगों ने सुना होगा, especially the former PMIK. He used to speak about this in every single function. वो is more from the political side. I'm telling you the more human side and more financial and social side. इलाज किसी बीमारी का भी हो, आपको पता है कि 3 तरीकों से होता है. One is OPD, where you need to go an outpatient setup. Second one is chronic medication, where for the longer run, you need to make a small spending. In both the situations, a patient, an ordinary person can manage somehow or the other, depending on his lifestyle, कि वो गली के कंपाउंडर को दिखा लेता है या आगा खान या शिफा के कंसल्टेंट को मेरे आपके जैसे बाबू जाके दिखा लेते हैं. But when it comes to the catastrophic healthcare expenditure, जब hospitalization की नौबत आती है, so situation is very different, very different. Last year, I was having a conversation with the State Bank Governor, and he was asking me, Arshad, do you know what kind of income inequalities prevail in Pakistan? And I asked him, I would like to hear from horse's mouth. Governor Saab, economy manager to aap hain, aap bataiye zara mujhe. कहने लगे Arshad Saab, 99%, underline, 99% of Pakistani population earn less than 100,000 rupees a month. 92% people earn less than 30,000 rupees a month. And 62.5% people earn less than 10,000 rupees a month. With this kind of income inequalities or income curve in our society, if tomorrow 2 a.m., God forbid, anybody of us or our beloved need any intervention, something like cabbage or angioplasty or any serious thing, कहाँ से आएगा वो पैसा? यार गरीब अमीर तो हर मुआशरे में होते हैं, right from Mexico to Tandovala, yeah. Everybody adjusts his lifestyle according to his income situation. लेकिन जब प्यारे की जान का मामला है, if somebody, you yourself or your beloved, तड़प रहा हो स्ट्रेचर के ऊपर, whether it's a prime minister's son or an ordinary laborman's son, तो फिर क्या होता है? वो खानदान उसकी जान बचाने के लिए सब कुछ दांव पे लगा देता है. घर, गाड़ी, जानवर, जेवर और कभी-कभी तो वो सब कुछ भी जो नहीं लगाना चाहिए. but still there is a 50% chance कि आपका प्यारा जिंदा सलामत घर लौट के आ सके. But in both the cases, that particular family will fall below the poverty line for the next 4 generations. इस मुसीबत के आगे, इस बला के आगे, इस इफरीत के आगे बन मानने के लिए हुकूमत पाकिस्तान ने 2016 के आगाज में कौमी सेहत कार्ड का इजरा किया. Initially it was started for the below poverty segment, but as I speak, this is the world's largest national health insurance program, which is 100% state funded, covering more than 170 million population of Pakistan. It is a miracle. It is something out of box. In a country like Pakistan, the fragile economy, vulnerable health sector, how is it possible? Wherever I go, to WHO, regional international forums, cabinet, World Bank, everybody asks, it's too good to believe. यार ये पाकिस्तान में मुमकिन है, पाकिस्तान में भी हो सकता है. 170 million. Only the Sindh and Balochistan are the missing federating units at present in Pakistan. Tharparkar is part of the program through federal funding. And we cover every damn indoor disease to be catered for. Oncology, cardiology, orthopedics, every damn thing. इसके बारे में सोच के भी आदमी को तसव्वुर में आए तो आपको छक्के छूट जाते हैं. How both financially and physically family and the person get damaged, uncurable, irrevocable. But we are doing this. Now, Pakistan health sector is being transforming. You are the practitioners. You are the players who are handling the services. I'm the one who just guiding the sector. But you are the guys who are doing the service. पहले सप्लाई साइड था, अब डिमांड साइड होने जा रहा है. पहले हमने अस्पतालों की जेब में पैसे डाल के 1 लाइन बजट के जरिए उन्हें कह दिया था कि ये 23 करोड़ पाकिस्तानी हैं, जब इन्हें इलाज की जरूरत पेश आए तो दे दीजिएगा. 80-90s तक मामला चलता रहा. After that, severe deterioration take place both in education and health. तो अमीर लोग तो प्राइवेट सेक्टर में चले जाते हैं, चाहे तालीम हो या सेहत. और गरीब लोग, जैसे मैंने शुरू में कहा, सरकारी अस्पतालों के फुटपाथों पे दम तोड़ते रहे. But now that's not the case. अब हमने क्या किया है? What we transform, we just simply take out the money out of the pocket of the hospital and put in the citizen's pocket in terms of the health card. अब आपकी चॉइस है, मेरी चॉइस है, एक आम मजदूर की चॉइस है, एक वजीर आजम पाकिस्तान की चॉइस है कि वो कहाँ जाना चाहते हैं. पब्लिक सेक्टर हॉस्पिटल A, B, C, D, प्राइवेट सेक्टर हॉस्पिटल E, F, G, H, wherever you want to go. जो अच्छी सर्विस देगा वहां जाएंगे. Public sector hospitals are no more cost centers for the government of Pakistan, and for that matter for the provincial governments. They are becoming now revenue centers. जो अच्छी इलाज करेगा वहां लोग जाएंगे, जो अच्छा इलाज नहीं करेगा वहां फुटफॉल ड्राई होता जाएगा. मैं पिम्स के बोर्ड ऑफ डायरेक्टर से खिताब कर रहा था, and I was telling them the time is over. जब आप पेशेंट्स को ट्रीट करते थे अनवांटेड गेस्ट के तौर पे, अब जो मरीज आएगा उसके पैसे मिलने हैं आपको, उसके नखरे भी होंगे, उसकी सर्विस एक्सपेक्टेशंस भी होंगी, उसका सर्विस फीडबैक भी होगा, उसके बाद क्लेम मिलेगा आपको. But it will take time. It will take time. थोड़ा सा टाइम लगेगा, स्पेशली पब्लिक सेक्टर प्रोवाइडर्स का पैराडाइम सेट करने में. But as far as the private sector are concerned, out of 1,050 hospitals across Pakistan, from Karachi to Gwadar, 70% private, 30% public sector, they are fully engaged in servicing. Every single day, 20,000 plus hospitalization taking place. Every single day, as I speak, more than 100,000 people are confined under the Sehat Card facility. Yes, this is taking place. And last thing I would like to say, फर्क क्या पड़ा, इम्पैक्ट क्या आया, तब्दीली क्या हुई. ए, पॉवर्टी एलिवेशन. अब किसी को ना घर बेचने की जरूरत है, ना गाड़ी, ना जेवर, ना कुछ और। बी, पब्लिक हेल्थ सेक्टर, आप सब मेडिसिन के पब्लिक हेल्थ के स्टूडेंट्स हैं। पहले क्या होता था, जब डेरा बुगटी के अंदर कोई वबा फैला करती थी तो सिर्फ कोयटा तक खबर आने तक हफ्ते लग जाया करते थे। एंड फॉरगेट अबाउट इस्लामाबाद, रेड जोन, मिनिस्ट्री ऑफ हेल्थ, वहां तो खबर आते आते महीने गुजर जाते थे। उस वक्त तक डेरा बुगटी और सराउंडिंग में कुश्तों के पुश्ते लग जाते थे और वो सारे मरीज पूरे पाकिस्तान में ट्रेवल करके उस वबा को हर कोने में फैला दिया करते थे। उसके बाद वो मीनस, वो फ्रीट, वो बला अनकंट्रोलेबल हो जाती थी। बट नाउ with the Sehat Card program, we have a real-time data. Every single patient admits in any part of Pakistan, you can see a real-time data with the provisional diagnosis, with the attending doctor, with the prescriptions, with the diagnostics, every single thing. And every doctor and every hospital working on our panel is now accountable for the service. We are introducing very soon STPs, standard treatment protocols, which are nowhere in Pakistan. So all these things are going to happen. And without your help, I must say, majority of doctors, 98%, 99%, majority of hospitals, they are soldiers of my army who are making it possible. कि लोगों को अब बेबसी की मौत मरने से हम नहीं छोड़ते अब. Everybody just need to get out from his pocket his computerized Shnakhti card and can go to any hospital and get 100% cashless treatment without any documentation, any further processing, any red tapes whatsoever. And now very soon, we are publicly going to announce, just for your consumption and for your house, I'm telling you, we are connecting every single practitioner's PMDC number with the hospital and patient service. Every end of the year, any period, we can just dig out Dr. X, Dr. Y, Dr. Z's PMDC number and his patients and services and complaints and performance. And we would love to recognize the best doctors, the best hospitals. We not only penalize the bad one, but we would love to encourage as well, incentivize them, reward them, respect them. It's not too far. And with this real-time data, and we are sitting, I'm just coming from a conference in the Marriott with the health and technology conference. But now we have a data gold mine, more than 8 million admissions. Everything is available. Just put in the AI machine, get the predictability of all the disease prevalence, disease burden, disease prognosis, whatever it is. So you can do a better service to your own people, to your own citizens. So I request and I expect from all of my colleagues sitting here in this room and those who are not around, you can convey my message. We need to work hard to make a health a real right to every citizen of Pakistan. Thank you. मैं आपके पहले सवाल का पहले जवाब दे देता हूं। जब हमने 2021 के आखिर में हम यूनिवर्सल करने जा रहे थे प्रोग्राम को 1 जनवरी 2022, so I had a lot of pressure on me from the cabinet. आदि के सारी कैबिनेट वो फॉर फोर्सिंग प्राइम मिनिस्टर कि जी हम जैसे पहले बिलो पॉवर्टी में हेल्थ कार्ड जारी करते थे उस तरह हेल्थ कार्ड जारी किया जाए। लेकिन ड्यू टू माई लॉन्ग एक्सपीरियंस, मोर देन क्वार्टर सेंचुरी नाउ इन द इंटरनेशनल एक्सपीरियंस, मैंने कहा ये पाकिस्तान में हमने नहीं करना, अदरवाइज हेल्थ कार्ड बनाना और इसकी इशुएंस एक और कमाई का जरिया बन जाएगी। तो व्हाट वी डिड, with just a magic stick, all the Shnakhti cards available in your pockets or your patient pockets, now they are health card. We don't need anything else. But what are the covered areas of health card as we speak? Islamabad, whole of Punjab, more than 12.5 crore people, AJK, GB, KP, FATA, and District Tharparkar of Sindh. Balochistan has already agreed next year they are going to join the program, and Sindh is considering at the moment. So after joining of both the federating units, it will be the biggest ever state-funded health insurance program. Second, as I mentioned in the beginning of my talk, that we are covering only inpatient health services at the moment for the health card, not the outdoor one. While I understand there are the dire need, not only for MS, but some other diseases as well. In due course, we will also try to include all these missing parts. And also the primary healthcare. We are integrating primary healthcare and preventive healthcare with the program. But believe me, it will take a little time. It took 140 years after the Bismarck model to the Germans. The Germany is the oldest health insurance nation in the world. It took them 140 years for the universal health insurance. And we done it only 7 years. बाहर जब मैं जाता हूं तो लोग पूछते हैं कि ये पाकिस्तानी कौम ये कैसे कर लेती है। हमने कहा बस ये सोया हुआ शहर है, जब तक सोती रहती है तो सोती रहती है। जब
इनपेशेंट अगर जैसे स्ट्रोक हो, एक्यूट स्ट्रोक है ना, वो तो इमरजेंसी, अगर एक्यूट स्ट्रोक का मरीज अस्पताल में जाता है उसको पूरी केयर आपको मिल जाएगी हेल्थ कार्ड।
जी
तो हेल्थ कार्ड तो हर बंदा इसके बाद सीएनआईसी है।
जी जी।
तो पाकिस्तान में सीएनआईसी तो पंजाब, सिंध और बलूचिस्तान को छोड़कर पाकिस्तान में तकरीबन 150 मिलियन के पास
17 करोड़ तकरीबन है। जी जी, शनाख्ती कार्ड काफी है।
चलो फिर इसके ऊपर वर्किंग करते हैं कि अगर हमारे स्ट्रोक के मरीज जब अस्पताल में पहुंचे तो उनको फुल केयर मिलनी चाहिए उनके हेल्थ कार्ड की बुनियाद पर।
श्योर, वो ऑलरेडी मिल रही है और मजीद कोई कमी बेशी हो, कोई गैप्स हो, यू कैन ऑलवेज मेंशन टू अस एंड वी कैन लुक इनटू इट।
पेशेंट ट्रीटमेंट को भी करें तो हमारी सजेशन ये होगी कि आप दिमागी बीमारी को प्रायोरिटाइज करें ताकि कम से कम उनको आउट पेशेंट ट्रीटमेंट मिल सके। तो थोड़ी महंगी ट्रीटमेंट तो ले लेते हैं लोग, ब्लड प्रेशर वगैरह की दवाइयाँ, ये दवाइयाँ जो 8-10 लाख रुपए की आती है, इस तरह की दवाइयाँ भी मिल सके।
बिल्कुल ठीक है, आपकी बात दुरुस्त है।
बलूचिस्तान वालों ने पिछले साल उनके पास कोई दूसरा सेहत एहसास कार्ड था या कोई था, इसमें उन्होंने अवेलेबल कर दिया था दवाइयों को लास्ट ईयर बलूचिस्तान में, तो उन्होंने पर ब्लॉक हो गया।
जी जी, कोई एहसास कार्ड नहीं था, कभी भी नहीं था। सेहत कार्ड एक ही है, उसका एहसास से कोई ताल्लुक नहीं है। ये वजारत सेहत का इनिशिएटिव है। जी, मैं गुजारिश करता हूँ, मैंने आपका सवाल समझ लिया और सुन भी लिया है। वो बेसिकली एंडोमेंट फंड बनाया हुआ था चीफ मिनिस्टर साहब ने, उसके जरिए वो रन कर रहे थे। इसी तरह जीबी के अंदर भी एक फंड है, वो रन कर रहे हैं। लेकिन उस किस्म के जो इनिशिएटिव्स होते हैं वो आमतौर पे शॉर्ट टर्म पॉलिटिकल इनिशिएटिव्स होते हैं जिन पे आप बहुत ज़्यादा रिलाय नहीं कर सकते। दिस इनिशिएटिव या ये जो प्रोग्राम है आज के दिन डेवलपिंग वर्ल्ड का, मैं ख्याल है शायद डेवलप्ड वर्ल्ड का भी सबसे बड़ा पॉलिटिकल सोशो पॉलिटिकल इनिशिएटिव है। Last year when we signed the universal health insurance program, it's over $3.5 billion US। 3 हुकूमतें ये ऑलरेडी ये प्रोग्राम देख चुका है। वरना तो आपको पता ही है हमारे यहाँ प्रोग्राम जैसे नई हुकूमत आती है तो नई चीजें बन जाती हैं, पुरानी चीजें लपेट दी जाती हैं। तो बट रेस्ट एश्योर्ड, सफर लंबा है, आहिस्ता है, कर लेंगे आपकी मदद के साथ। बहुत शुक्रिया।
Thank you, Arshad Saab. Thank you for the very thought-provoking talk. So next talk is about a patient's perspective. So I'm very happy to invite one of my dear patients. She's herself is a PhD doctor, and let's welcome Dr. Fakhira. So she will briefly discuss the challenges she has faced in this MS journey in the last 5-6 years.
Assalamu alaikum. Good evening. My name is Fakhira. I'm from Wakent, and I am basically a teacher by profession. And recently, I'm doing my simulation and modeling research in physics from PIAS. I've been diagnosed in 2019 and when I was 30, and it was very hard for me to accept the reality that I have been bounded by such an invisible disease. My early symptom was fatigue and my foot drop and frequent urination. That actually put me in so much trouble, like I cannot perform the daily task. So at first I was not believing it, like I'm having such an invisible disease and I cannot explain it to anyone. After some time, I visited many doctors and no one was getting me like what's wrong with me, because I cannot explain the symptoms. And these were some early symptoms, and actually I was doing job and I was lecturer in university. So it was very hard for me to deliver a lecture for 1.5 hours. So being physicist, it was very difficult, like to stay on board for 1.5 hours. So my colleagues and my students were keep checking me like, what is wrong with this ma'am? And they were saying like, you can explain to us, but I cannot explain my symptoms to them because I was actually not getting it to myself as well. So it took me so long, like it took me almost 2.5 years to accept the reality. Like it is there and I have to accept that. No doctor was complaining, like they were saying like, you are very weak and you are probably having some muscular weakness, so you should need some multivitamins and you need to think about your diet plans and you need to focus on dietary plans so that you can focus on your daily routines. After some time, I have visited a neurologist in Cont'd International Hospital. He asked me to have some tests. He asked me to get some CSF done and some scans. And when I came back with the results, then he was saying like, you are a patient of multiple sclerosis and I'm seeing you in next 10 years on the wheelchair. So it was very hard, like how can I be bounded, because I was very functional and very active. I was basically a sports coordinator as well. So it was very hard on me, like psychologically it broke me in pieces, like how can I be patient of multiple sclerosis, because I was keep checking me like how can multiple sclerosis affect my daily life. So it even didn't give me a second thought to start a treatment, because he was saying like, you have to start some DMT. And I was like, ये कैसे हो सकता है मेरे साथ, ऐसे तो हो नहीं सकता, मैं इतनी एक्टिव हूँ, मैं इतनी फंक्शनल हूँ, तो ऐसे कैसे हो सकता है कि मैं इतना बाउंडेड हो जाऊँ. और फिर उसके बाद फिर मुझे तकरीबन एक साल लगा, और then someone referred me towards the Dr. Farheen Niazi, and at that time she then again referred me some recent scans, and after recent scans she said like, you have been aggressively attacked by your disease, so you need to get on some DMT. I was keep negating the fact like I should not try some DMT. And she was so kind and so humble. Like she was saying me, you have to accept the reality. This is there. You need to live with it. You need to set your new normal. So I then gathered some amount with my savings and all that, and I came up with my first infusion with the Ocrevus in July 2020. And I was doing pretty good with this Ocrevus. After that, after 6 months, I was then caught by COVID-19 and the Muniel attack. And again, I was bedridden. My research was actually on simulation. So I have to work 8 to 10 hours on the console. So some of blurry vision was the symptom that I was facing at that time as well. So I was like कैसे हो सकता है ऐसे कि मैं अपनी PhD को भी कंटिन्यू करूं, क्योंकि मैंने तो स्टडी लीव ले ली थी यूनिवर्सिटी से, और मुझे ऐसा लगता था कि जैसे बहुत लाइफ से अब बहुत स्टक हो गई है. सो लेकिन मैं क्योंकि ऑक्रेवस लगवा रही थी, और आई वाज डूइंग गुड, आई वाज डूइंग फिजियोथेरेपी एंड ऑल दोस supporting aids as well. So फिर मैं डॉक्टर फरहीन नियाजी को मैंने कहा कि ये तो बहुत ज़्यादा एक्सपेंसिव ट्रीटमेंट है, इसके लिए तो बहुत मुश्किल है कि मैं मैनेज कर सकूँ इसको. तो फिर उन्होंने मुझे एक और बहुत अच्छे और बहुत काइंड और बहुत हम्बल डॉक्टर से इंट्रोड्यूस करवाया, डॉक्टर हारिस मजीद से. ही देन टेल मी कि यहाँ पे बहुत सारे रिसोर्सेज हैं, जैसे PVM का सपोर्ट केस था. सो मैंने 3 केसेस जो उनसे हैं वो PBM के 2.5, वो PBM के सपोर्ट से फिर आई हैव बीन इन्फ्यूज्ड बाय ऑक्रेबस. और अभी मेरा 5th प्लान है ऑक्रेबस इन नेक्स्ट वीक. एंड जो मेरा मेन कंसर्न है वो ये है कि वंस आपको अर्ली डायग्नोसिस हो जाए और आपको एक बहुत अच्छा सा आपको कोई बैकअप मिल जाए बाय योर डॉक्टर्स टू लेट यू नो कि अब आपको अर्ली स्टेजेस में आपको कौन सी DMTs को फॉलो करना है और आपको क्या स्टेज फॉलो करनी है. सो वो बहुत अच्छा हो जाता है किसी भी पेशेंट के लिए टू एक्सेप्ट द रियलिटी कि ये है और इसको आपने कैसे लेके चलना है लाइफ में. मेरा अभी भी मेजर कंसर्न यही है कि मैं एज सुन एज पॉसिबल मैं इंडिपेंडेंट लाइफ गुजार सकूँ जैसे आई वाज लिविंग विद. और सबसे बड़ा इशू ये होता है कि क्योंकि इफ समवन इज बिलोंगिंग टू सम वाइट कॉलर फैमिली तो उसके लिए बहुत मुश्किल हो जाता है टू अरेंज दैट ऑक्रेबस और एनी DMT. सो जैसे वो सर ने कहा अभी कि हम वर्क करें इसके ऊपर, सेहत सहूलत कार्ड के ऊपर भी, और भी बहुत सारे रिसोर्सेज जैसे आई केम थ्रू. तो मुझे लगा कि मतलब ये बहुत अच्छा हो जाएगा पेशेंट्स के लिए, ताकि वो अपनी डिजीज़ के साथ जो बाकी जो साइकोलॉजिकल इफेक्ट्स होते हैं और बाकी जो चीज़ें उन्होंने अपनी लाइफ में उन्होंने कैरी ऑन की होती हैं, तो बाकी जो आपके बहुत सारी मोटिवेशंस होती हैं, आपके बहुत सारे गोल्स होते हैं, उसके साथ सम अप करते हुए अगर ऐसी कोई रिसोर्सेज मिलते जाएं तो पेशेंट के लिए बहुत आसान हो जाता है टू सेट अ न्यू नॉर्मल. थैंक यू सो मच फॉर हैविंग मी हियर. थैंक यू सो मच.
आपकी पहली सिम्टम आने से डायग्नोज होने के दरमियान कितना वक्त है? साल, 2 साल, 3 साल?
इट वाज अबाउट 2 years सर. क्यों
किसी ने बताया कि आपको MS है?
फ्रीक्वेंट यूरिनेशन मुझे ज्यादा इशू था.
2 साल से थी?
हाँ जी,
डायग्नोज 2 साल के बाद?
2 साल के बाद हुआ. थैंक यू सर.
Thank you, Fakhira, for your nice, kind words. Mashallah, she has been very brave throughout her journey. So next I invite Dr. Maria. She is from Multan. So let's hear her.
Mariapura. जी जी. नीचे मारिया यूसुफ भी है.
डॉक्टर मारिया, किस नाम से आपने यहाँ पे पहले? मारिया नजीर या मारिया यूसुफ? मारिया नजीर. तो हम आपको ऑन ले रहे हैं, ठीक है ना? मारिया नजीर ये भी पेशेंट है, मुल्तान पे.
कर दिए सर.
जी अस्सलाम वालेकुम एवरीवन. जी अस्सलाम वालेकुम एवरीवन. आई एम डॉक्टर मारिया Nazir. I am patient of multiple sclerosis. As we all know that MS is a disorder of demyelination. In this disease, the body's immune system attacks the protective covering of nerve cells. This is known as myelin sheath. How I developed this disease? I developed this demyelinated disorder when I was house officer in National Radiology Department. I firstly developed numbness of left leg and left forearm. Then muscle spasticity. I had disturbed gait, ataxia. I thought that it is simple muscle stiffness, maybe due to overwork or over fatigue. So I consulted my orthopedic doctor. He gave me some painkillers. He thought that it is sciatica. So I took this treatment for almost a month. So suddenly I developed stiffness of left leg and the left forearm. Gradually, I was unable to move my left side. My professor of radiology advised me MRI scan. As I told you people that I was house officer in radiology department. So he diagnosed some lesions in my brain and paraventricular region, midbrain, pons. So he said that this is multiple sclerosis. I was really very much upset to hear all that. I was thinking how I will spend the whole life. I was bedridden gradually. Then I had IV treatment of solomedrol, methylprednisolone, and also some oral tablets, delta-cordal. I took it for almost a month. Fortunately, मुझे काफी उससे बेहतर हो गया. I was recovered and I was feeling better. At the time, everybody said that beta-ferrons is the most effective treatment of that disease. So I took beta-ferrons injections for 2 years, but it didn't work. मुझे कोई खास फर्क नहीं पड़ा उन टीकों से. So after that, कुछ अर्से बाद, I developed a vascular necrosis of left hip joint, and I had my hip joint surgery twice, not once. So it was very challenging for me to move on walker. I was totally bedridden. So after that, I realized that ये सब कुछ कब तक चलेगा. Gradually, with the passage of time, I realized that I have to live with this MS. I changed my lifestyle according to MS. I decided to, after that, मुझे चलने में कुछ बेहतर होना शुरू हुआ जब इस avascular necrosis की सर्जरी कर ली. I was on bed for more than 6 weeks. So after that, I decided to leave my bed. So I joined a medical college and I teach pathology, which was a very good experience. And that was very encouraging for me that at least I can do something. So after that, I also supervised a lab, private lab over here in Multan. So it was very encouraging and nice experience. Aasta aasta, I realized the nature of the disease. In this disease, sometimes a patient develops blurring of vision, which is a very common feature of a disease. A very interesting experience I want to share with my friends. कि blurring of vision मुझे develop हुई. I went to an eye specialist. He said that your eyesight is totally normal. That is 6/6. But I was unable to see from left eye. मुझे कुछ नजर नहीं आ रहा था. मैं बहुत परेशान हुई कि भाई ये तो कह रहे हैं कि मेरी आईसाइट बिल्कुल नॉर्मल है और मुझे कुछ नजर नहीं आ रहा. मुझे मेरे न्यूरो फिजिशियन ने गाइड किया कि दिस इज ऑप्टिक न्यूराइटिस, जो कि 6 वीक्स के बाद सेटल डाउन हो जाता है. सो फिर आफ्टर 6 हफ्ते के बाद हमारा ऑप्टिक न्यूराइटिस सेटल डाउन होना शुरू हो गया. एक यूरिनरी रिटेंशन में और यूरिनरी इनकॉन्टिनेंस पेशेंट बहुत सफर करता है. मैंने भी सफर किया. मुझे बड़ा प्रॉब्लम हुआ यूरिनरी रिटेंशन का भी और यूरिनरी इनकॉन्टिनेंस का भी. फिर उसके बाद मोर ओवर मैंने आहिस्ता आहिस्ता डिजीज के फीचर को अडॉप्ट करना शुरू किया. देखा कि इसमें इन्वायरमेंटल फैक्टर भी इन्वॉल्व होता है. एग्रेसिव जो एनवायरनमेंट होती है, बहुत ज्यादा कोल्ड या बहुत ज्यादा हॉट वेदर, वो पेशेंट को बहुत डिस्टर्ब करता है. मैंने भी सफर किया इन चीजों की वजह से, अभी तक करती हूँ. सो आई हैव टू plan my schedule and my life according to this disease. And I also plan my routine and my schedule to prevent myself from MS fatigue. Zyada stress, zyada over fatigue is very harmful for MS patients. Then luckily I met Dr. Wasay in AKUH and also in other seminars of MS in Nishtar Medical University. It was a very good experience. Dr. Wasay is a blessing for the patient of MS. He encouraged me and increased my morale and said not to get afraid of MS. So उन्होंने मुझे बहुत हौसला बढ़ाया, उन्होंने मेरी बहुत encouragement की. So today Allah Ta'ala का शुक्र है, Alhamdulillah, my life is going on very smoothly. और ये सब अल्लाह ताला की मेहरबानी है और मेरे डॉक्टर्स ने काफी मुझे सपोर्ट किया. So this is it, all my MS story. So I pray for my MS patients to not to get this hard और काफी इंशाल्लाह ताला अल्लाह ताला अच्छा रखेगा. And my best wishes for my MS friends. And thank you so much, all of you, for giving me this opportunity to express my views with you people. And thank you very much. God bless you all.
Thank you, Dr. Maria. You have been very brave. Dr. Wasay, if you want to say something about her journey. Oh, okay, so we'll move on to our next session. Next talk is a panel discussion. So there are 3 participants. Miss Saba Abbasi, she will be joining on Zoom. She is from Genzyme. Then we have Mr. Kamran, he is from Roche. And then we have Dr. Tayyaba. She is a medical director of Ehsaas tahafuz program. So to moderate this session, I invite Dr. Majid.
Thank you everyone for joining for the session, Mr. Kamran and Dr. Tayyaba and Dr. Saba online. So we'll start with each of you. If you can say a few words regarding your portion with respect to MS.
Assalamualaikum. Thank you so much. I'm from Sehat tahafuz program that was previously known as Ehsaas tahafuz program. It is a social protection public sector development program that is under the Ministry of Poverty, Elevation and Social Safety that provides free health coverage to the extremely poor patients for the treatment, including multiple sclerosis. We received the request for the treatment from our impanel hospitals that are 14 hospitals all over the Pakistan, including the Gilgit, Baltistan and Kashmir. All the 4 provinces, Balochistan, Sindh, KPK and Punjab. So we process that through an efficient and transparent digital automated IT system that was provided by Bill and Melinda Gates Foundation. So far, Ehsaas tahafuz program has impaneled 14 public sector hospitals all across the Pakistan, and we are providing the approximately 900 treatment packages totally free of cost. Sehat tahafuz program has currently approved more than 15,000 treatment packages. We provide both the IPD and OPD patients. Regarding neurological diseases, we are specifying multiple sclerosis. We are providing the treatment as an IPD and OPD. We receive on daily basis multiple sclerosis treatment, and especially regarding the octafus injection, rituximab, even the plasma exchange, MRI scans. And we have also multiple success stories of the patients that we get feedback from our impaneled doctors. So our treatment don't have any limit. That is for the Ocrevus if patient is coming for the first dose and after 2 weeks they need a repeated dose of Ocrevus. Yes, we provide 300 milligram, I think, for the first 2 doses, and then for the next 6-month doses is 600 milligram. Yes, we provide. And Ocrevus injection is around one single vial is around 3 lakh rupees. So we don't have any limit. For the same patient, we can receive multiple requests unless the patient is cured. So same with the plasma exchange, either they are having OPD base, IPD base. So this is how.
Which 14 hospitals? You have to, the person has to be poor to get the dose,
Yes.
or anyone who goes to those
No.
hospitals?
No, we have 3 checks. First of all, patient should not have received any treatment from the State Sahulat card, or they are not registered with the State Sahulat card. Other is their PMT score, that they should be less than 44. And third, their survey that they are poor, that is done on the bedside and from the BISP data. So whoever is on that criteria, we just give the treatment.
Which hospital?
Yes, we have pamphlets of that. We can just provide you that 14 hospitals name.
In the country.
Yes, overall Pakistan. Yes. Musa, can I have one? So that. Yes, sir. Sir, we have 3 checks. Extremely poor. That have PMT score. PMT score is a score that is calculated under a BISP, Benazir Income Support Program. So, sir, there is State Sahulat card that they are not receiving treatment from any other that insurance or Sehat Sahulat card. And the other is, and doctor, they evaluate, they generate the request. Yes, yes, yes.
How do we find out? For example, if someone comes to us as a doctor, he says, I am poor. Okay, I want to get that injection. How are you going to find out if you are, or we find out?
Sir, first thing starts.
Request and then you find out.
Sir, I think we should go through this card. Okay. So first of all, it's like doctor, first of all, patient comes to doctor. Doctor will assess the patient. They will assess whether the patient need the treatment or not. Okay, they got it that they need the treatment. Then doctor will send this patient to State Sahulat card desk. And they will check if he or she is eligible or not. That previously they have utilized the State Sahulat card or registered with that card or no. If they are no, then doctor send treatment request to tahafuz with the app.
How do we send?
Sir, each doctor, we have in each impaneled hospital, we have panels of a doctor. For example, I have a very good interaction with Lady Reading Hospital, Dr. Zia. I think most of you, yes, sir, because most of, I don't know what is the cause, but most of the request I receive for the multiple sclerosis is from KPK, Peshawar. So,
Their doctor, Dr. Zia, send you the request.
yes.
And then you decide on the next.
No. Then we have a verification officers in hospital. They go to the patient for the determination according to the BIS survey. That is a survey that is already automatic. They go through that and that calculate the PMT score. So if that is less than 44, so patient is eligible for a treatment.
And then you pay to the patient or pay to the company for the treatment or pay to the hospital?
Okay, so we pay to the hospital once the patient received the treatment. Patient received the treatment. Okay, a patient is eligible. Patient got the treatment. We will receive the patient documents, evidence base that this was patient history. This is the doctor sign and stamp. This is the treatment they received. Then we receive in the PMU unit. And then I, being a medical director, I evaluate the patient documents, whether patient was eligible or no. This is the same ID card number. This is the patient criteria. Here it is mentioned multiple sclerosis and patient came with disability or optic neuritis, whatever, and how the patient was treated, whether it was the... Yes, we deal with the hospital. We don't provide the... Yes. 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 For example, sir, Octavus वो hospitals में नहीं होगा. Each hospital they have their procurements. जिस भी pharmacy से है, they will provide us a non-availability certificate कि वो hospital के पास नहीं था, and we just bought from that pharmacy. We receive all the invoices. And when I'm okay with the medical documentation within 24 to 72 hours, I will request that hospital that just start with the treatment of this patient. There should be no delay. So we will pay. After that, once patient receive the treatment, I receive the invoices, non-availability certificate, pharmacy certificate from there where they bought. And after that, we pay that to the hospitals. हम patients को नहीं देते. Or it's all transparent, it is all automatic.
Question number 2, how do you come up with these 14 hospitals? What is the criteria? For example, since you have identified Veer Abdul Qadir Hospital, Gambar, how did you come up with this hospital?
So we have a committee in ministry of steering committee meetings. So we are actually to be true at the moment due to the crisis, due to the flood. One thing, the other financial crisis ongoing in Pakistan. So we have just limited our treatment packages and we have a limited hospital further empanelment. In 2023, we are about to, that we discussed that we need to empanel 20 hospitals or 30 hospitals. But at the moment, I think you all people know that we don't have finances. Okay, Islamabad mein, it's Holy Family Hospital. Okay, let me say in Federal Capital Hospital CDA, but here we were providing cochlear implant. So far, overall Pakistan, we have done 176 cochlear implant surgeries, totally free of cost, less than 5 years old children. And cochlear implant for one patient cost around 15 lakh rupees. And after that, speech therapy, their rehabilitation therapy, we have paid all that. Successfully, we have done 176 cochlear implant surgeries. And so CDA was empaneled for the cochlear implant surgeries. In Punjab, Holy Family Hospital, Nishtar Hospital, Children Hospital, in Sindh, Gambart, in KPK, Lady Reading Hospital, Khyber Teaching Hospital, Hyderabad Medical Complex, and DHQ Dera Ismail Khan. In Balochistan, it's Sheikh Khalifa bin Zayan Hospital, Shaheed Mohtarma Benazir Bhutto Hospital. In Gilgit, it's Provisional Headquarter Hospital Gilgit, Regional Headquarter Hospital Gilgit, and in Kashmir, it is Abbasi Institute of Medical Sciences, Muzaffarabad. So in future, inshallah, we are receiving multiple requests from different public hospitals to empanel. So soon, sir, hope we get the funds, we get the budget. Okay, sir. So, sir, whatever in these empanel hospital, we can just provide you with this information. Sir, yes, we have data, but exactly the number I cannot tell you at the moment. We have a monitoring wing. वो हर hospital, हर province और हर province में कहाँ से patient आया था. We have each and every data available. Thank you, sir.
Thank you, Dr. Tayyaba. To my knowledge, neurology के setup के हिसाब से it's not really operational in Islamabad and Pindi. Holy Family में there was one neurologist who is properly left. तो उनके भी cases अब इधर ही आ रहे हैं. तो वो I think आज की conference का फायदा उठाते हुए we would request that you adopt some neurology based hospital in Islamabad or Pindi, government setup में, which can take up these medications. And to my knowledge, I think जो सबसे ज़्यादा effective आपकी साइड से प्रोग्राम चल रहा है, that's in KPK and Peshawar basically, and they have the most number of patients who are getting free medications and pretty quickly as well. Yes. And
Maybe I have one patient for the medical sclerosis, and they are a patient who after 6 weeks they are there for the next dose, or after 6 months they are for the next dose. So they are regular patients, and even I met with the patients which are chal nahi sakte, but after our treatment they are able to walk, they are able to see.
Secondly, जो एक और point regarding evaluation system, which is probably done independently, जो poor poverty evaluation होती है उनकी, उसमें unfortunately क्योंकि MS की treatments इतनी costly हैं कि वो normal affording बंदा भी ज़्यादा अर्सा afford नहीं कर सकता. 1 or 2 years perhaps तो उसके लिए पॉसिबली एक कंसिडरेशन होनी चाहिए कि वो बेस्ट वाले क्राइटेरिया से उनको बाहर निकाल के एज अ स्पेशल केस कंसिडर किया जाए, because this is an ongoing disease. ये chemotherapy उस तरह की नहीं है which would go for 1 or 2 years. It will continue for a longer period of time, and they even affording patients will become non-affording within 1 to 2 years or perhaps even 3 years. So that could be considered as a special case, क्योंकि इसमें longer term therapies required हैं, and they're obviously more expensive.
One is the BISP score, other is our verification officers. They are in each these impanel hospital. They go to the patient. They also re-verify. We have some cases, for example, last 2-3 months back, I received a request of the multiple sclerosis for the female. I don't know, she was widow and she was teaching. She has multiple sclerosis. Now she has no job. She has to take care of her kids also. So in that case, जो BISP के data में था, she was working. So after that, we changed that. Now she's widow, she's not working. So वो according to patient bedside भी evaluation होती है from our verification officers. So we reconsider also that, and we just go to that patient कि आप BISP में ये चीज change करवाएं. You are most welcome. और to be true, sir, hospital में जो हमारे doctors हैं, वो बहुत passionate, बहुत motivated हैं. कोई patient होता है, बहुत needy होता है, they directly call me कि kindly इस patient को reconsider कर दें. मीन कि आपके उसमें क्राइटेरिया में नहीं आ रहा. सो सर हम लोग किसी भी तरह फैसिलिटेट होता है, हम डॉक्टर से कहते हैं ओके गो एंड टेल दिस पेशेंट टू डू दिस, वो वहां पर ये चीज दे दें, ये प्रोवाइड कर दें, वी विल गो विद दैट. सो वी नेवर से नो टू एनी पेशेंट अनलेस कोई सम केसेस डू कम के वो फजूल में ही आ रहे होते हैं, किसी एक को फ्री ट्रीटमेंट मिला तो अदर होल कम्युनिटी इज कमिंग फॉर दैट. तो वी हैव सम चेक एंड बैलेंसेस. Audit भी होते हैं हमारे, so we have to do that check and balances. But to be true, oncology patient, multiple sclerosis, and other neurological diseases also we are treating, stroke patients, and all we provide them. And even we are providing the VP shunts for the kids. So we are never no to any patient. We are here to help our poor, and we are helping, and hopefully with further donation we will be continuing this program. Thank you.
Thank you again, Dr. Tayyaba. Industrial representatives से हम next discussion start करेंगे, but before starting that, I'd just like to state जो हमारे issues हैं regarding with the industry. Obviously, we have only 2 medications available which are approved. Ocrelizumab and teriflunomide, both are extremely expensive, unfortunately. और उसमें दूसरा जो support program है, even with that, they're still quite expensive. और जो बैतुल माल का support system available है for federal hospitals, federal government hospitals, वो भी limited है. That does not extend beyond 1 or maximum 1.5 years. Secondly, for rituximab, which is although off-label, उस पे Roche वालों से discussion भी काफी होती रहती है. उस पे भी support program की limitations और constraints हैं from their side. They are providing support program for other diseases, but not for CNS demyelinating disorders. So that I would request them to reconsider. So we'll start off with Dr. Saba first, and then we'll move on to Mr. Kamran.
Dr. Saba, go ahead. Unmute yourself.
Unmute.
Go ahead.
Can you hear me now? Hello?
Yes.
Yes. Thank you very much, Dr. Saba Abbasi, for giving me this opportunity to represent Sanofi Pakistan. Actually, Sanofi is operating from 2013 in Pakistan, and we are working on the rare diseases, that is the genetic disorders, enzyme replacement therapies, and multiple sclerosis. So for multiple sclerosis, we have 2 medications. One is teriflunomide, which is a registered product, which is an oral medication. And then we have Lemtrada, which is the alemtuzumab. Alemtuzumab pe kafi kam patients hai because it's an expensive medication, and it requires a lot of, the hardcore background working as well. So my pass, there were a few patients who are on Limprada, whereas for teriflunomide, Ubagio के हमारे पास patients हैं. जैसे Dr. Harris ने अभी mention किया कि expensive medications. I totally agree that it's an expensive medication, but it is an oral medication, and we have, different models to offer our patients as well. One is through the Pakistan Baitul Mal. Another is a patient assistance program that we have, and the patient, contacts either me or connects through the call center, and through that they get a discount. So and then we have the funds that we support through the government of Punjab and the government of Sindh. Dr. Wasay के अभी patients government of Sindh के साथ से approve हुए, उसके अंदर भी हम लोगों ने facilitate किया. We have good number of the patients that are supported through the government of Punjab, and that is also facilitated by Sanofi. So ये कुछ programs हैं जो हमारे patients के लिए हम लोगों ने design किए हुए हैं. रही बात cost की, so we are working with the global on the cost as well, or inshallah, fingers crossed that we will probably get further discount also that we'll be able to offer to our patients, but that is still under the consideration. So मैं आपके साथ commit या कोई promise नहीं कर सकती, but this is going to go like हम लोग किसी और कोई और discount policies जो आप suggest कर सकते हैं, जो हम लेकर आ सकते हैं, आप suggest कर सकते हैं, so that we can consider, we can discuss it with the global, and we can for the support of our multiple sclerosis patients हम आपके सामने ला सके. So if you have any suggestions to give, then you can always give it to me, and then I can forward it to the global on that.
Now, what is the assistance program? Like if they pay 2 months, and then you give them an extra month of treatment. How it is?
No, it's not like that. It's a consistent cost reduction, like 28% का cost discount उसको patient को मिलता है. अब जो पहले वाला था सर, ये था कि अब दो patient packs लेता था और एक free of cost मिलता था, या 3 लेता था और एक free of cost करता था. तो अब हमने उससे consistent एक discount offer कर दिया 28% का.
अच्छा, नहीं अभी इसकी जगह ये वाला प्रोग्राम आ गया है, तो उनकी कॉस्ट ओवरऑल कम हो गई है.
जी ओवरऑल कम हो गई है.
Thank you. We'll now move to Mr. Kamran for his comments and suggestions.
Thank you so much. I'm Kamran Abbasi. First of all, I would like to thank you, the organizing committee, for providing us an opportunity to represent Roche here and share our initiative for the patient welfare for MS patients. Talking about Roche, it has been in Pakistan from a long time in oncology segment, but talking about neurosciences specifically, we have launched Ocrevus in 2015 worldwide, and it became available in Pakistan in 2019. Globally, more than 300,000 patients have been treated with Ocrevus. And when we talk about Pakistan, last year, more than 500 patients were given the benefit of Ocrevus. And in this year, we are expecting double the amount of the patients that were being treated with Ocrevus last year. While talking about Ocrevus, it's the only medication that is approved for RMS patients and PPMS patients. When we talk about the cost, obviously the number of patients globally are in a huge quantity, but in Pakistan they are limited due to cost issues. But to counter that issue, Roche has its patient support program. According to that patient support program, we share the burden of the patient in a 50-50 ratio. For example, the total dose of Ocrevus is 600 milligram every 6 months, every 6 months. Sorry. In that case, the Ocrevus is available as a 300 vial. A patient has to purchase single vial of Ocrevus 300 milligram. The next 300 vial is being provided by Roche free of cost to that patient. That dose can be taken from our Anmol program coordinator. First of all, the patient purchases the commercial pack, and the FOC will be provided according to his need at the specific time at the specific institution. Other than that patient support program, we are also working with government bodies like Pakistan Baitul Mal, where Ocrevus is being registered. The patient who cannot afford Ocrevus can get a dose of Ocrevus from Baitul Mal, and similarly one dose of the Ocrevus will be provided free of cost to the patient from that way also. Other initiatives include like we are working with Ehsaas tahafuz, we are working with Sehat tahafuz,
We are working in coordination with Sindh government, in coordination with Punjab government and other relevant governments like KPK and Balochistan for incorporation of MS as a disease in their therapeutic area as a universal card. They're saying that they have a universal health card policy, so MS should be enrolled in that criteria as well. And then we can provide the benefit of Ocrevus to those patients as well. The same will go in their products as also. The patient will have to bear a cost of 50%, and the rest of the 50% of cost will be bared by Roche itself. So these are some initiatives that are being taken by Roche for the betterment of MS patients. We will be obviously we will be accepting your suggestions, and we will be forwarding it to the global regions as well as per your need at time to time, and I will look to overcome all those hurdles.
So with that, we'll conclude this panel discussion, and hope that the industry contribution will continue, and they can come up with a cost cut soon, inshallah, and we can have a sustained program for their drug provision through various government programs as well. So now. Thank you for inviting me for the concluding remarks. So it's been a pretty exhaustive and extensive session. I would like to thank everyone, the industry representatives, the doctors communities, the neurologists who have come in, Dr. Tayyaba and other support systems representatives who have come, and especially our patients who have participated, Dr. Fakhira and Dr. Maria, who's participated online. So special thanks to everyone, and especially our patients. And hopefully we can continue this process, and we can have more such training programs as well as patient-oriented programs, which will improve and help in basically improving our patient care, our diagnostics, and also sharing our own experiences, especially with the patients registries and patients exposures, and with the newer upcoming therapies. So with that, we'll conclude today's conference. Thank you. Jazakallah khair. Assalamu alaikum wa rahmatullah.